I would like to welcome Good morning. I'd like to welcome all of you to the 9th Annual Research Symposium of the Center for Chronic Disease Research and Policy, based in the Department of Medicine at the University of Chicago. I'm Albert Huang, Director of the Center. I'm a general internist and clinical investigator here at the University of Chicago. So the Chronic Disease Center was established 9 years ago, and our vision is to create a world where healthcare research and policy seamlessly interact to improve the health of individuals at risk for or living with chronic diseases. And our mission is to develop and study innovations in the care of individuals at risk for living with chronic diseases and to influence the policies that affect the financing and organization of care. So we are meeting virtually, and we are talking about virtual healthcare. Prior to the pandemic, we already had some of the basic contours of telemedicine, or what we are calling today virtual healthcare. In this pre-pandemic figure from the New England Journal of Medicine, we have clinician-to-clinician communication. We have clinician-to-patient communication as well over video, phone, email, remote wireless monitoring, and the internet. And then there was also the idea, and the technology already existed, for leveraging data collected by patients outside of the clinical encounter. This included the use of wearable monitors, smartphones, mobile apps, video, email, web portals, and games. This, of course, was at a time when I don't think any of us was using Zoom in 2017. So why are we meeting today to talk about virtual healthcare? Well, we've just lived through nearly 2 years of a COVID-19 pandemic, and this pandemic has forced rapid change in clinical practice, population health, but also in payment policy. So suddenly, during the middle of 2020, we were trying to meet patients via Zoom, and later using an Epic application in a kind of clumsy way. And then to address huge drop-offs in routine laboratory testing and screening tests, we initiated large-scale population health outreach, at least here at the University of Chicago. Almost every aspect of outpatient care required improvisation. So we've invited 4 speakers today to address some fairly big critical questions about virtual healthcare now and for the future. So can we use the pandemic to answer questions like, what parts of medical practice worked well virtually? What did not? How did virtual healthcare impact health disparities? And if we are to address barriers to delivering virtual healthcare, what are most important to address disparities? Is it broadband access? Is it digital literacy? Or is it something else that we haven't thought of? And what is next for virtual health and healthcare policy related to coverage of virtual healthcare services? So this is a schedule of today's speakers. And so you can see we'll begin with Sachin Shah, moving on to Megan Heising-Sheets, Tim McBride from Washington University, Scott Lawrence from CMS. All 4 speakers will be joining us for an extended question and answer period between 12 and 12:30. We will break for lunch at that point and then return for our poster presentations from 1 to 1:45. And I'm happy to announce that our poster presentation awardees are Xian Zhao, Sarthik Agarwal, and Jessica Chang. Congratulations. I'm also happy to announce 2 new programs that are hosted by the Center for Chronic Disease Research and Policy, both very relevant for young investigators. And I hope if you are not interested in these opportunities, that you'll please forward them to others who might be. So the first opportunity is a new fellowship program that we just started in the last year, led by Nita Lai Tirapong, a CDRP Associate Director. And the fellowship is called the Primary Care Investigators Training in Chronic Disease and Health Disparities, the PITCH Fellowship. And the overall aim of the fellowship is to train the next generation of primary care clinical investigators to improve health outcomes and care delivery for patients with chronic diseases from underserved backgrounds. This is a 2-year fellowship for those trained in internal medicine, geriatrics, pediatrics, and infectious diseases. We're particularly interested in having a fellow interested in addressing HIV. This is a 5-year HRSA T32 fellowship, and we have 2 fellows per year. And this is the link for the fellowship to learn more information. And I'm happy to announce that we have our inaugural fellows are Nate Glasser and Nicole Pierce. And within the last month, I'm happy to announce that we were recently awarded a $20 million 5-year multiple chronic disease health disparity center from the NIMHD. Our center is called the Chicago Chronic Condition Equity Network. We are one of 11 regional centers scattered across the country. This is a collaboration between University of Chicago and Rush University. So the important thing for young people is to look out for pilot grant announcements, probably in early 2022. These pilot grants will be up to $50,000 per year. So Mary King will be sending you out evaluation forms for today's symposium. It's our 9th annual. We always try to improve the symposium. So please complete those evaluation forms for the program. The talks from today will be posted on YouTube and on our YouTube channel. This is our website, chronicdisease.uchicago.edu, and please follow us on Twitter for new announcements about opportunities and research activities. All right. Mary, is it okay to move on to introduce Sachin? All right. So I'm happy to introduce our first speaker, a close friend and colleague. Our first speaker is Sachin Shah. He's a primary care med-peds physician boarded in internal medicine, pediatrics, and clinical informatics. He's an associate professor of medicine and pediatrics at the University of Chicago, where he also serves as associate chief medical information officer. His work focuses on population health, value-based care, digital health, telemedicine, ambulatory quality, analytics, and patient engagement. He really does it all, in addition to speaking to congressional staffers about telehealth policy. So Sachin, we're happy to have you here. Are you ready to share your screen?
Yep. Thank you, Albert. Can you guys see that screen okay and hear me okay? All right, awesome. Well, good morning, everyone. Albert, thank you so much for inviting me to speak at this symposium, topic that's near and dear to my heart. I'll just, start by providing sort of an outline. Well, first of all, no disclosures, no conflicts of interest. And sort of the objectives that I want to cover in the next 40 minutes or so. I'm hoping to leave some time for questions before the extended Q&A session. I want us to sort of think about, reflect on the really rapid transition we made to telemedicine, especially in the ambulatory space. There's been a lot of early lessons. It's been, about 18 months now, just over. And, we've had the opportunity to reflect back on some of our data and our experience to date. And there's a number of key lessons to take away and to help us inform kind of our path forward. The current state of reimbursement, telemedicine reimbursement, somewhat complicated, somewhat uncertain, and I want to just talk about that, review kind of the current state. And then, health disparities are a very, very big part of the discussion that we have and the analysis that we make and the path that we chart forward and when it comes to telehealth. and digital transformation as a whole. So I want to speak to that. And I want to make sure we have a few takeaways in terms of goals for us as clinicians and healthcare professionals to advocate for the right policy to promote telehealth and specifically equitable telehealth, as I think digital transformation is going to be a really key part of the way that we deliver healthcare in the years ahead. So the first lesson, and I kind of have this structured as lessons, and then we'll sort of delve into the details behind all of those. We can do telehealth. Albert showed that slide in the intro from 2017. We've been ready to do this for years. We've had the technology. Many of our patients have had access to that technology. Patients have been seeking virtual care well before the pandemic. And the barriers that we always kind of worried about have proven surmountable. And the necessity sort of the pandemic very kind of acutely in March of 2020 helped us get there very quickly. Virtual care is safe. The costs of the technology are manageable. State licensing restrictions, even though this was sort of done piecemeal and in a very temporary way, and a lot of these sort of waivers are unfortunately expiring as we speak, if they haven't already. But these barriers have proven surmountable. Patients, fundamentally they want to do virtual visits because it can reduce some barriers, and I'll talk a little bit more about that. The big thing that changed, of course, in March of 2020, that really brought this this new era forward was reimbursement. It was led by CMS. The private insurers quickly followed, and that coupled with the needs that we had, especially around safety for not only our patients but for our providers and our care teams. And it was by now we all know some versions of these numbers, whereas just looking at Medicare data, whereas in February of 2020, 0.1% of all primary care visits were conducted via telehealth. It was 43.5% between that mid-March to early June period in 2020, the early kind of months of the pandemic and the stay-at-home orders. When you look at adults aged 50 to 80, we saw 4% had ever done a telehealth visit in May of 2019, and that was over a quarter by the early months of the pandemic. Just looking at our own experience at UChicago, we saw, like many places around the country in healthcare, we were down to 23% of our ambulatory volumes in the first couple of weeks of May. And we rapidly pivoted, as so many of us did across the country, to virtual visits. And we saw pretty quickly by June a rebound to 92% of our ambulatory volume. We had never done a virtual visit as of March 26th, 2020, when we did our first ones in a pilot phase. And by May we had 25,000 done. By the end of September we had done 120,000 in the first 6 months. And at the time, in those first couple months, by the end of May, between the very beginning of April and the end of May, that represented 60% of all of our ambulatory visits. So that was pretty dramatic, a really, really important part of continuing to be able to offer care for our patients. Again, this is not a unique story, but this is still a really striking pivot in how quickly we developed that capacity. So I'm here to share some of the longer view data now. So after that full year, after the first full year, we had done over 210,000 virtual visits. 75% of them were video visits. And those 210,000 virtual visits over the course of that year, when a lot of patients again began to return to in-person care, it represented still over a quarter of all visits in that first year. Looking back, just at the view from today, after about 18 months, we've done over 280,000 virtual visits at UChicago. 22% of all visits, that still represents over a fifth of all of our ambulatory visits over the last 18 months have been done virtually. And just over 75% of the virtual visits were video visits. This is kind of a breakdown of the proportion of virtual visits, the pink bars are video visits and the blue bars are telephone visits. I'll come back to that in a minute, but I wanted to just give a quick overview. Last week, this is just our data from, a couple of our sites. This is here in Hyde Park, 86% now, just looking kind of at a week to week level, 86% of all of our visits are on site here in Hyde Park. A couple of our surrounding sites outside of the south side of Chicago are doing a little more on site. And of all of our virtual visits, still about 80% down here in Hyde Park are done by video, and closer to 90% are done by video on some of our surrounding locations. The second lesson is patients like telehealth. When we looked at our Press Ganey data from the summer, the first summer of the pandemic, July of 2020 through just the end of the spring, this past spring, we saw that video visits were rated actually just as high, if not higher than in-person visits. And that's, with a pretty big sample size, 56,000 plus patients. Patient priorities, when it comes to healthcare, they're going to prioritize safety, especially in a pandemic, convenience, and timely care. That's going to be priority number one. A second priority, of course, is continuity of care. And so ideally we have both, but if forced to choose, patients have shown us time and again that they're going to choose the primary priorities of convenience, timeliness, safety over that continuity. And that's going to be an important part of how we think about our models of care, that integrate virtual care and telehealth into our care delivery transformation plans. And one of the big reasons that patients really like virtual care is that for many, it can reduce barriers. They don't have to take time off work. They don't have to arrange child or elder care. They have less concerns regarding transportation. We can be involved as family members and caregivers in the care of our loved ones. These are really important advantages of telehealth and virtual care. Just some other data, I won't go through it all, on patient satisfaction. You can see very, very highly rated when looking at telehealth visits. Communication was rated as strong. It removed barriers, as I mentioned, increased convenience. And I mentioned a lot of this already. And 2/3 say that it reduced the costs. Virtual care was less costly for them than in-person care. And this one I'm going to spend a little time on. This, telemedicine. I think this is a really key part of how we need to think about the path forward. Telemedicine can really help support new models of care delivery, and I'll go through these. Telehealth helps us develop a more continuous relationship with our patients. Things like digital tools that we give patients access to, they can a good example, I think, and this is true across the country now, patients have direct access to their results, test results, through patient portals. They, as of April of 2021, this past April, 6 months now, the 21st Century Cures Act has mandated that patients have access to all their notes. So the open notes, and that type of access and that type of engagement, we share through our portal, what patients' preventive health status is, what are their care gaps, what do they do for. That type of transparency, I think, is really fundamental, because patients who are reading their notes, who are looking at their results, who are communicating with their care teams, they're engaged patients. Patients who have access to self-scheduling, patients who can self-schedule their mammograms, for instance, when they see that they're due. These are activated patients, and patients who are engaged and activated and are able to help self-manage some of their conditions when given the agency through a lot of these digital tools. That has a direct relationship on improved health, and we've seen that time and again. Activated, engaged patients are healthier patients. Telehealth, can be a really, and in virtual care overall, can be a really important tool for preventive health, primary care, stable chronic disease management in a very cost-effective way. Now, this doesn't mean that, you know, we don't have to sort of reorganize the way that we have set up our care teams and the way that we manage this. But looking at it objectively, and I'll show this in the next slide a little more schematically, but sending a message for a low complexity, low acuity, easy question, sending a message through your patient portal to your provider or your provider's RN that they can answer is actually a really cost-effective way to get low acuity, low complexity care from your provider and care team. I'll come back to that. Asynchronous care, so that's an asynchronous way to do it. Other asynchronous, models of care using digital tool. There's RPM, which is remote patient monitoring. So, hey, I want to, have high blood pressure. And we have a great example of a recent pilot program that we've launched here a couple of months ago with our obstetrics group. Women who had hypertension during their pregnancy-induced hypertension, and needed follow-up care. Instead of having them come back every week, every 2 weeks for a blood pressure reading, or a couple of them in the course of a 10, 15, 20-minute office visit, and everything that comes with that. You have a newborn, you're driving down, probably bringing your newborn with you, parking, navigating here, paying for parking, the convenience factor. Instead of doing that, we are sending patients home with a device that measures, their blood pressure at home and their heart rate and other things, syncs with, a Bluetooth. It's Bluetooth enabled. It syncs with their, with an app on their phone, and it gets reported directly to us, and we can monitor that. So we can tell, okay, how are you doing with your blood pressure control? Maybe I can send you a message back and say, okay, let's make this adjustment based on the last 10 readings over the last couple of days. So remote patient monitoring, there's a lot of iterations of that, of course. That's one use case that we've started here recently. Asynchronous care, structured questionnaires, e-visits, where we can actually get the information we need. The patient can complete that at 10 o'clock at night if they want. And then we can look at it the next morning, their care team. That's actually, again, a really efficient way to have a more continuous relationship with our patients, a more cost-effective way to deliver care, and in a really important part of how we manage things like chronic disease moving forward, especially relatively stable or low complexity chronic disease. Decoupling care. So up until recently, and honestly still, for the most part, me getting the care that I need often depends on me kind of coming and seeing my provider, my primary care physician or my specialty provider. I might only get that ends up being the bottleneck. I'm seeing my physician or my provider. And what we need to do is decouple care. Again, in combination with that transparency piece, if I know my care gaps as a patient, if I have the agency to self-schedule my mammogram or my colonoscopy or my lab work or my vaccines, and I can just come by, get that taken care of at the lab because I have the orders, or I self-scheduled my test because I knew that I was due for it because I have access to that, then I don't have to wait for my primary care physician's appointment, which might be 3 months out, or my specialty provider's appointment. I can just take care of it. I can get it done because I know, and my provider, my care team know what I'm due for, and we're sharing that record. And there's this transparency. And again, if I'm given the agency to do that, I can do that. I can do it myself. That reduces a lot of the burdens. That expedites the right care that I get. And kind of looking at these, the ones that I just mentioned, we can think about the concept of risk stratification. We have a ton of data on our patients, not only embedded in the electronic health record, but from a lot of other places as well. But we can use a lot of data to risk stratify our patients, right? So there's, I alluded to higher complexity care and lower complexity care, higher acuity, lower acuity, stable chronic disease. If we can effectively risk stratify our patients, which we can, again, the lower acuity, lower complexity care a lot of that can be done asynchronously or perhaps virtually and synchronously sometimes. But what that can do is it can free up in-person, visits for higher complexity, higher acuity care that requires, actual a person to be there in person. Procedural things are a good example of that. And from a business, standpoint, that actually, that higher complexity care is higher revenue care as well. And it helps us, sort of allocate the resources, the limited resources that we have in a more effective and data-driven way. And finally, it really telemedicine and sort of virtual care models would really thrive under a more capitated value-based care approach to reimbursement. If we're constantly looking for CPT codes that, in a fee-for-service system for things like, okay, every e-visit, every patient advice request, every sort of analysis of a remote patient monitoring data set, it's, we're going to struggle with the administrative burdens of that. Again, however, under a capitated model, that, hey, if you take better care of your patients do better. They have less acute care utilization because of all these tools that you are using. And you see the benefits in terms of upside risk, for instance, then that's a much, I think, a much more flexible way to value and incentivize this type of care. And in this schematic that I was talking about, if you have like your lowest complexity routine stuff that can be handled by community health workers, population health nurses, members of your care team, like your MAs, your LPNs, your RNs, advice requests coming in through the patient portal asynchronously, routine preventive health. Maybe you need maybe your MA can put in an order for that care gap that's shown, to you and to your care team, and you have the protocols in place to do that. And then, you can do things like lower complexity urgent care, stable chronic disease management. That can also be done, either asynchronously or virtually synchronously. And then that actually does, free up space, and access is such an issue for every, every sort of healthcare center, ourselves included. The higher complexity care and the more active, management of chronic diseases and other things, we free up in-person resources and other kind of resources, things like care coordination and more sort of encounters for those types of needs and those types of patients. Again, this relies on appropriately risk stratifying our patients and their needs, but we have the ability to do that. Next lesson is video visits are better than telephone visits. Compared to telephone visits, we know that you can do things with video visits like, some aspects of a physical exam. Patients rate video visits more highly. They feel they can establish a better connection with their patients. There's more understanding, satisfaction at a very practical level. A video visit counts as a face-to-face visit when you need to enable, get approval for home health services, whereas a telephone visit unfortunately does not. And our clinicians, when we surveyed them, reported similar advantages to video visits, and that relationship and that connection and that trust is obviously really a key part of longitudinal care. Reimbursement, there's also benefits to video visits in terms of reimbursement, because if you spend 10 minutes preparing for a video visit, you spend 25 minutes on the video visit, and you spend 10 more minutes documenting on that same day of the video visit, you can count all 45 minutes. On the telephone visits, if you spend 10 minutes before and 10 minutes after, but 25 minutes on the phone in discussion, you can only bill for those 25 minutes. And there's still some uncertainty regarding, telephone visit reimbursement, whether it will continue. There's been a number of proposals under which telephone visit reimbursement goes away, and that's I'll talk a little bit more about that. The next lesson is about the digital divide, and it's real, and it's really it's huge, and it's a real concern for all of us. It should be, and certainly for our patients. The major barriers to accessing telemedicine, as you know, we talked about some of the benefits. There are many, but there's a lot of barriers to accessing telemedicine. The absence of technology, of course, low digital literacy in broadband access. Albert alluded to some of these. And the groups that traditionally struggle to access telemedicine services are the ones you might expect. I don't think there's a lot of surprises. The elderly, those with lower socioeconomic status, minority racial groups, those with lower levels of education and non-native English speakers. Again, I won't go over this, but just the technology piece. I know a lot of there's data out there. 80% plus of all adults have access to things like smartphones and tablets and even computers, but less than or almost half of adults over 65 have never used video conferencing technology. This was not pre-pandemic. This was mid-pandemic. This data set. Over a third of households, headed by someone over 65, don't have a computer, desktop, or a laptop. You can see the digital literacy data, which is really telling as well. Over 50 million Americans don't know how to use a computer. And again, this concentrates in some of the demographics that I mentioned earlier. And then broadband access, I'll come back to that a little later too, but digital redlining is a real issue as well, especially in rural America, but also in a lot of pockets of urban communities. And a lot of those are the communities, are communities predominantly of color. So, and it doesn't, the digital divide is not just important for healthcare. Of course, it factors into so much of an individual's social well-being. It's, I think widely recognized now as a social determinant of health, very appropriately. Access to things like education, housing, livelihood, economic opportunities, food, groceries, social services are all really linked to your access to broadband. And healthcare is one of many of these factors. We see chronically high prices in poor communities for very substandard service. We see both rural communities and urban areas struggle with access. And as I mentioned, communities of color are less likely to have this access versus predominantly white communities. I'm going to do a case study, of our data, which I think is emblematic of a lot of other places. Of course, we're here on the south side of Chicago. We have these zip codes that we consider our service areas, some of our most underserved neighborhoods that we are that we serve on the south side of Chicago, and this red box kind of highlights that. The areas that I'm mentioning, there's a lot of medical and pharmacy deserts within this. I mentioned the digital redlining, which means there just isn't widespread access to things like broadband, and there's just not a lot of healthcare infrastructure. So I'm coming back to this figure that I showed you earlier. Over the course of, from the beginning of the pandemic until the end of the spring, I'm gonna just enough data to show you on one screen comfortably. This is the pink boxes the pink bars, the video visits that we completed, our patients completed, and the blue ones, the telephone visits. So overall about an 80-20 split. That looks okay, right? This is the percentages now, and I'm going to stick to the percentages here as I move forward. About an 80-20 split, video versus telephone. When we look at our white patients, a little bit higher in terms of video visits, and I tried to make the case earlier that video visits are better than telephone visits. 83, 84% if you look at the calendar year 2021. We look at Black patients, you can see it goes down a little bit. It's more like 70 to 73% are able to do video visits. When we look at the South Side, now we're starting to bring the neighborhoods in, goes down a little more. We're through much of the pandemic, it was closer to 2/3, 1/3 split. If you look at this calendar year, we're hovering around 70%, 70-30. Now, if we look at age overall, 65 plus, I'm kind of going through these risk factors that I mentioned, the demographics. So when you look at just 65 plus, this is everybody 65 and over. We're closer to 60, 62, 63% are able to do video visits. Now, if we start putting this all together, Black and 65 and on the south side of Chicago, all of a sudden the majority of visits now are telephone visits. So this is, I hope, a telling kind of example of, again, we look back at this overall volume. Okay, 80-20, that's not bad. Video visits versus telephone visits. Maybe we'll take that. But when you look at our focus on our highest risk patients, they are not able to access the same level of care. And there's a number of reasons. I'll show this in slightly differently, kind of that same time period. This is a summary of, this is in-person visits. This is on-site in-person clinic visits, about 587,000 of them. Look at that distribution, equal percentages basically of white patients and Black patients were able to, they came in person. This was from the beginning of the pandemic to the first year. But when we look at virtual visits, look at that disparity between the difference between white patients versus Black patients in terms of accessing video visits for those that were doing virtual visits. When we look at telephone visits, kind of flips the script here. Primarily much larger percentage of telephone visits were done by Black patients versus white patients. When we look at payer mix, again, back to on-site, in-person clinic visits, about 36% were Medicare, 27% were private payers, or Blue Cross specifically. When we look at video visits, however, again, sort of flips it right on, flips it right around. The commercial payers and specifically Blue Cross beneficiaries were able to access video visits at a much higher rate than Medicare beneficiaries. And when we look at telephone visits, this is the most dramatic. Our Medicare beneficiaries, by and large, 65 and older, represent a very disproportionate segment of our telephone visit population. There's been a lot of these analyses that have been done that show very similar data. We published one as well earlier in the pandemic, and the lessons from these analyses, and this is not a unique story for us, is a lot of what we've been talking about. Less internet access, lower literacy, digital literacy translates to lower likelihood of completing a video visit. I showed you kind of our analysis. The ones that struggled the most in our population were the elderly, our Black patients, and our Medicare and Medicaid beneficiaries. The other analyses, saw similar things, but also, showed that those with lower socioeconomic status, the unhoused, non-native English speakers, and rural residents were also in those most vulnerable groups. These are unfortunately the same patients who disproportionately experience the worst outcomes for common chronic diseases, and also had the highest COVID morbidity and mortality rates. And the map of Chicago over here shows you, darker the color, the more sort of cases among Chicago residents. These maps, you could put a lot of different captions on the same maps. So what can we do what can we do about this? And this is another lesson that came out, is we can take steps to promote more equitable access. It starts, of course, with monitoring numbers, like I showed you, but of course it has to be much more than that. We have to mitigate the barriers, and that means the resource barriers and the digital literacy barriers. Things like offering video visits to every patient. Let's not make assumptions over who can or can't do it. If someone doesn't feel comfortable doing it, then we have to support them so that they can do it. one of the great things about virtual care and video visits in particular is how easy it is to embed language interpreter access, either sort of automated captions in a lot of systems, or just inviting a interpreter to join the call. That makes it very easy. But what I really want to focus on as well here towards the end of this talk is the policy changes that we need to advocate for. And we saw some of this already, and I've alluded to it already around broadband access, reimbursement parity, telephone visits, continuing to reimburse telephone visits. But it really fundamentally starts with understanding our patient's perspective. We can sit here and talk about what we think our patients need, but fundamentally we have to ask them, and we have to engage with them. And with the focus on them, we need to hear it from them. We need to partner with civic organizations and faith communities that are closely embedded in the community where our patients are. We have to meet them where they are, and we have to listen to their stories and respond. And we have to understand, from their perspective, what the true barriers are. Lolita El-Qureshi, who's a colleague of ours here in pediatrics, and Wei Wei Li, who's one of my colleagues in general medicine, and a number of students, and I help with this too. We conducted a qualitative study recently to understand the perspective, and Lolita and her team analyzed 54, 55 patient interviews, and trying to understand the barriers from their perspective. And there's a lot of frustration among many of them, many patients. Everything is go online. We old schoolers don't know anything about going online. We're limited in the information we can get. And that's coming out. It was like Sunday. They told us that it was accepted for publication. So that's coming out probably in the next week or two. We'll share that. The Digitally Disconnected, a qualitative study of patient perspectives on the digital divide and potential solutions. It gives a ton of insight into our patient's perspective, and I think we need more of these, qualitative assessments to understand where our patients are coming from. We have to give more resources to our patients, things like guides and checklists for successful video visits that go through things like, technology requirements, patient-facing materials that we developed here in partnership with our patient and family advocacy board. What we also did through the last 18 months, we embedded in all of our ambulatory clinic standard work to share the links for all this information in our appointment confirmation messages, our reminder messages, whether or not patients were active on the portal. We published a multilingual resource list with community and neighborhood specific details around places where you can access digital tools, broadband, digital literacy resources. I think we have to keep working hard to keep surfacing these and sharing these with our patients. From the provider and care team perspective, we've very much learned that telehealth visits require just as much support, if not more, than in-person visits. I think probably early on we thought, okay, this should be pretty easy. We'll just get on Zoom and wait for our patient to come on, and then we can go ahead and do our visit. That did not work. We often spend 15 to 18 minutes of our 20-minute visit, trying to get in touch with our patient and say, hey, did you get the link? Or, hey, I can't hear you. Or, hey, did you, there's an app that you have to go to and download and open up. Did you, were you able to do that? And then by the time you get your patient in front of you, if you do at all, the visit's over, and you have 3 people waiting for you. That's a common experience from the early days. What we shifted to pretty quickly was patients receiving pre-visit phone calls from the care team as part of not only a triage process, but a really important digital navigation role that often MAs would play. Basic digital navigation, like, okay, do you have that link in front of you? If not, I'm gonna text it right to you. What's the best number? Is this the best number to text you? Then just click on this link and it should open up your video, and then, okay, oh, I see you on there. Okay, great, you're ready. Your provider will be coming on in a few minutes. Again, it's not a very, it's not like we're standing up a tech support team, but it's providing basic digital navigation to help reduce some of these technology barriers and to help improve success rates of video visits. We had a small medical student-led coaching program where adults who were interested in additional support would enroll in that and indicate that. And medical students would call them and walk them through video visit steps. And that was a really helpful, successful program that patients rated really highly, and so did the students. They really enjoyed connecting with some patients that way. Lolita and Weiwei and others, including myself, published this observational study, also looking at clinician perspectives. 350 of our Chicago Medicine clinicians and their perspective. And the big takeaway here was that the barriers that providers talked about, the greatest barriers to telemedicine and to engaging with patients, virtually were the patient barriers that we've just spoken about: digital literacy, access to technology, broadband. So our barriers are our patient barriers, and again, it really behooves us to work on those. Resource allocation is another really important part of how we do things. And I talked about risk stratification, and this is another iteration of that. So we've developed a predictive analytics tool where we've actually just finished. Well, we're very close to finishing the work on this, where we look back and for patients who were scheduled for a video visit but ultimately had to convert to a telephone visit, basically had an unsuccessful video visit, what were the factors involved? And then we developed this this video visit kind of risk score based off of the variables, and that helps us risk stratify our patients. Those who are at highest risk of being unable to complete a video visit. And then, instead of having to call all 12 patients on my schedule, let's call the four highest risk ones, the ones that are highest risk of not being able to do this successfully, based on the variables that we know. And let's allocate our limited sort of digital navigation resources to those patients. And this is how ultimately it'll show up. These are screenshots from Johns Hopkins, where they developed this already, and we're, like I said, we're in the final phases of validating ours. JC Rojas, who is a Plum critical care physician in medical informatics, board certified in clinical informatics, and our clinical informatics fellow Sonia Makani is also working on this. And they're very close to being ready. Actually, we're meeting tomorrow to talk about finalizing it. Next lesson is reimbursement. So we saw how reimbursement, in March of 2020, really drove this rapid change in enabling, telemedicine, this new era. But it can also slow everything down. So we know. A lot of so much of the pieces in place right now that are enabling telemedicine rely on the public health emergency being ongoing. And so it was declared at the end of January of 2020. It's been renewed repeatedly, most recently a week ago, yesterday. And we know that it's going to last at least through calendar year 2021. We've been told that we'll get a 3-month heads up before it expires, but there's still a fair amount of uncertainty. And will telehealth reimbursement last beyond the public health emergency? And until and unless we know that, it's going to be very hard to invest long term in a lot of the infrastructure that we need for telehealth to make it part of ongoing long-term care. And there's a lot of bills under consideration in Congress. Albert alluded to a couple conversations that several of us here have had with some of the committees, including Ways and Means. And there is support for permanent coverage, but there's a lot of nuance here in terms of what that means. Like, how much are we going to cover? What are we going to cover? at what cost. And that's really going to impact, like I said, our planning and investment in the infrastructure and innovations we need. And obviously it's a concern of providers and care teams. Almost 3/4 of providers cited reimbursement uncertainty as a barrier to maintaining usage after the PHE. And what this, you might ask, like, hey, haven't we sort of figured this out over the last 18 months? We're doing it. So what's the problem in terms of investments? Telehealth, a lot of these platforms, video visit platforms, they were designed, to operate without sort of any involvement of reimbursement. The pre-pandemic telehealth was largely out of pocket, or it was covered as a benefit for, certain, health insurance plans. And so, one of the big things we need and to make this work long-term is, building in things like automated real-time eligibility checks, so you can understand what the coverage is for a patient given their insurance, what their copay is, what their benefits are. And that takes time. That takes a lot of investment to build that. And like a lot of things in medicine, back-end billing drives up the cost of care. And so, this was a question posed over a year ago, in the New York Times, like, is telemedicine here to stay? The same question applies today. I'll go over a couple of sort of key facts, around reimbursement. And this goes all the way back to the Balanced Budget Act of 1997. There was a provision there, a section in the Social Security Act, part of the Balanced Budget Act of 1997, that prohibits Medicare from paying for telehealth services outside of an originating site in a rural area. So that means, you had to go into a building in a certain geographic rural area to be able to get reimbursable telehealth services. Now, when the CARES Act was signed in March of 2020, that gave CMS the authority to waive that geographic origination requirement and allowed Medicare beneficiaries to access telehealth from anywhere, and specifically home, and regardless of where they live. So it took away that rural, the requirement for being in a rural area for the first time. Now, again, this is right now, CMS has that authority as long as the PHE is ongoing, but we have to imagine at some point it's going to end, probably, in the near term. In the nearer term, then it's much closer to the horizon than I think it was certainly a year ago. And so this is what Congress has to do. This is why we need Congress to act. If that section of the 1997 Balanced Budget Act is left in place, then most Medicare beneficiaries will lose access to telehealth services at the end of the PHE. So, that work is underway, but again, it's far from certain what that's going to look like. So, in a nutshell, for me, the reimbursement priorities. So we have to continue reimbursement for telephone only visits. I hope the data that I showed you from our own experience here on the south side of Chicago shows that why it's a matter of health equity. We need payment parity between in-person video and telephone visits. What our experience to date in the last 18 months has also shown us is that telehealth visits have been substitutive. That means they have replaced in-person visits. They haven't been additive. We haven't seen the net volume of ambulatory visits. If you total up in-person video and telephone, it hasn't gone up. It's actually, the video visits and the telephone visits have replaced some in-person visits. And there was a lot of concern, I think, in the early on about, is this going to lead to overutilization of healthcare? We have not seen that. The data, there's been several data sets that have shown that it's been substitutive and not additive. I just alluded to this. We have to remove the geographic restrictions and the originating site requirements. We have to figure out a way to solve this physician licensure issue. This is a constant struggle. It dramatically slows down the ability for telehealth providers to, we live here in Chicago. We have a lot of our patients in Northwest Indiana, in Michigan, and Wisconsin, and the licensure issue is an ongoing administrative burden for all of us, and it slows down the ability to provide care to patients that we care for routinely in person from different places. There has to be alignment, right? There shouldn't be a difference between how Medicare pays for a video visit versus how Medicaid pays for a video visit versus how a commercial payer. Generally speaking, our commercial payers and Medicare are aligned. Medicaid doesn't always align, and we have to ensure that has to be part of our part of what we advocate for reimbursement wise. Otherwise, we really do risk introducing a structural disincentive to caring for certain types of patients with certain models of care. I talked earlier about value-based care, capitated payments. Telehealth is made for this. Flexible, innovative models of care delivery. And you incentivize these innovations by really shifting to capitated payments long term to support telehealth. I think making permanent the coverage of preventive health telehealth services and care transitions, if we're trying to reduce readmissions and we're trying to improve advanced care planning and Medicare annual wellness visits and preventive health, wellness visits, chronic disease management, that has to be part of what we cover permanently. TCM visits and Medicare annual wellness visits and behavioral health. On top of that, for things like substance abuse treatment and psychotherapy and neuropsychological testing, psychiatry and psychotherapy, will never be the same. The amount of the dramatic shift to virtual care has been such a benefit for access to behavioral health services, and should continue to be just the standard that we provide and cover without geographical restrictions moving forward. Advocacy goals, we've talked about this at some length as well. Universal broadband is so fundamental. States have to allocate funding towards developing infrastructure and providing digital technology to households. The FCC should require all internet providers to provide low-cost options. We need technology access initiatives. We talked a little bit about this. Communities need to develop programs to provide, training and teaching about how to use technology to patients who lack access. We can even consider covering certain telemedicine, devices, smartphones, remote patient monitoring devices as a medical benefit, because it's so fundamental to getting the care that you need as we evolve towards these more digitally transformed healthcare delivery models. The digital literacy programs, to patients who are afraid of technology, have also repeatedly said that they're willing to learn, that they want to learn how to use it, but we have to support them. We have to develop these programs to help improve digital literacy, so that our patients are able to access the level of care that everyone deserves. And then finally, these platforms, we have to really push our vendors, EHR vendors like these video visit platforms. We have to push them on the user experience, not just for providers, but especially for in care teams, but especially for patients. We've had this trend for a long time of primarily innovating for those that are already digitally literate and well off, and we sort of ignore the patients like the elderly, like the Medicare and Medicaid beneficiaries. Those are the ones that, by and large, those are the patients that are shouldering a disproportionate burden of chronic disease and high complexity care. Those are our most vulnerable patients. If we keep innovating exclusively for those who are well off and already digitally literate, of course, the digital divide is only going to grow wider. And so we have to demand that the commercial vendors, with hopefully things like academic industry partnerships and other types of innovative solutions, really focus on the patients that need it the most, and frankly who have been left behind. We have to do that with intention, and that's one of the ways that we can start closing this this unconscionable gap, honestly. I will stop there, and I'm happy to take some questions now, and then we'll have some time in the extended Q&A as well. But thank you for your attention.
Thank you so much, Sachin. That was a great opening talk that provided direct insight into what happened at the University of Chicago, while also highlighting the policy, the specific, very specific policies that affect whether or not we can continue to evolve in this part of medicine. I am, unfortunately, we've gone overtime, so I think we're going to formally end this session, and we will hold questions that we have for Sachin for the extended Q&A. Mary, are you ready? Are you ending the recording?
Yes.
Okay, let me know when you're ready to start.
Okay.